and welcome to today's ECG conference. I'm happy to chat somewhat. So I'm going to show 3 ECGs for the same patient for our discussion. So this is the first ECG.
Okay. I think we only need 2 fellows now. So you want to start reading ECG?
There's written regular heartbeats, approximately 75. Here included normal sinus rate requires
Okay.
normal.
Yeah, let's talk a little louder. Sorry. Okay. You can see there, yes. You're the main guest.
Sinus rhythm, regular rhythm, then heartbeat is approximately 75 beat per minute. Sinus rhythm, sinus PR interval is normal. Sinus rhythm chorus complex is normal. Premature ventricular complex occurred. Quit interval is not prolonged. V2 to V4 leads ST segment 2 mm elevated. Okay. There's a trigger-mini PVC occurred. So that's it.
And so, can you summarize for us what the ECG show?
We want to which relates are where we want to we violates are yes like quest shaped, maybe old instruction that I think PVC shape occurred maybe left side, I think.
So, what you're saying, patient is sinus rhythm.
Sinus rhythm.
P wave is normal.
Yes.
How about QRS axis of sinus? Is a normal axis or a little bit deviate to the leftward?
Left.
Right. But it's still within the normal conduction range.
Yes.
Why that? Lead 1 is a pure R. Lead AVL has a small Q now, is R. And then ABR is quite positive, right? So it's not an extreme northeast axis, okay? So, and then other additional you talk to us about is V1 through the V4. There is actually V5 abnormal Q wave, right? And then you also discussed about the little S segment elevation, but does not appears to be acute. That's what you said. Possibly chronic previous MI. And the repolarization abnormality persists the entire precordial. Now, this PVC, where they're coming from? So PVC has every third beat is a PVC, right? So trigeminal pattern rhythm. And the preceding sinus rhythm QRS to the PVC interval is exactly the same, right? Preceding sinus R to the PVC is the same, correct? There's a regular PVC, monomorphic PVC, with the coupling is exactly the same, right? And the PVC shows slightly RS, and the lead 1 right?
Mhm.
Look at the lead one, small r, bigger S, notched 2, 3 AV positive, right?
Mhm.
And then lead 3, lead 2, AVF has a notching at the very top of the QRS complex, right? See that. And then V1 precordium, there's an R, right? Initially the R, V2 is R, V3 is R. And then I hard to see that V4, V5, but I think there's also R, but S is deeper. And then there's a weather transition. Do you see any transition R wave? No, we don't. Because the V6 is almost isoelectric, or they did not catch all entire complex. I can't tell, but probably isoelectric, I think, almost. So where is this PBC coming from? Normally people we say, oh, this is a outflow track, but then patterns are not consistent with it. If you have an outflow track, precordally the R wave should continue grow, right? Didn't grow. So where I think it is coming from. But AVR, take a look at the AVR, is Q, R, small r, Q. AVR is a maximum negativity, right?
Mhm.
So assuming that this is a focal origin rhythm, that where the deepest S wave without Q is most likely where the focus is. Because the impulse is going to go away from the focus to the other part of the heart. Make sense? So simply as we look at the for identification standpoint, the AVR, AVL is the deepest S wave without R wave, right? Like occupied my QS. So that tissue, that's where the focus originating. So would it be left ventricle, lateral, high lateral wall? But then how do we explain this transition of precordium? If it's a high lateral wall transition, should be have a reasonable pattern, not the V4, V5 still have a deep S wave.
True.
Almost like a biphasic.
Mhm.
Think of that way. That means a perpendicular to it, right? So is it possible? So it cannot be very high anterolateral.
Mhm.
Got to be a little lower. Okay. And then now put together. If this patient has an MI, okay,
Mhm.
a leggy territory, or maybe even, I don't see much different changes in the your any additional change you see in circumflex territory here, ischemic change. Do you see it? AVL, lead 1. There's a change,
Mhm.
right? So this patient perhaps had a significant insult. The left circulatory system, probably coronary artery, whether this is a, very proximal LAD or OM involvement, that we don't know, but that's the most likely possible mechanism. Okay. Anybody want to add on? Anything else? Because if you look at the V6, the QRS is normal, right? Only normal V6. So,
From the sinus rhythm, we see that the patient has a left anterior hemiblock.
yes, that's a lateral axis.
So could the pattern in V1 to V3 be because the PVC, though it's coming from the lateral wall, instead of depolarizing the left ventricle through the anterior, it rather goes retrograde through the right ventricle and then towards V1 to 3, which is why the R wave is rather increasing in V1 to 3.
Very unlikely. Why is that? If you're transmitting your impulse from the posteriorly, okay, vectorcardiographic speaking, you would see what?
Initially, it would be
Well, lead 2, 3 should be a little taller heart though, because the inferior, right? You're looking up. So if your heart is oblique, it's not a straight heart, right? So in order to rotate it posteriorly, you have to come towards the inferior first and then goes up.
Okay.
Then I expect to see taller R wave. Your thinking is correct. But however, as the left side comes up, wider, rotating counterclockwise, you have to pass through the septum first. Make sense? That's why the R wave there doesn't matter. It's a B1, B2, B3 has a taller R with the wider, duration. That's the reason. Yeah. Okay. Next, you had another ECG there. Can show us?
Yes.
Okay. Let's take a look.
Patient ECG. So,
Okay. Now what it shows? You can read it. Try to read it. See what you get. Mm-hmm.
Like lateral two to one weight condition of conduction and rate about 100 and quality is not slim like lateral wave and so here not measurable. Queries complex is quite narrow, like 40 to 80 milliseconds.
So what evidence do you have? This is HR flutter.
It look like, especially V1.
V1 shows the what?
V1's flutter will look like positive.
So you say this is a 2-to-1 flutter,
Yeah.
right? Okay. Can you go back to your first ECG? Look at the V6. Okay, that's R wave there, right?
Yeah.
And then PR's interval of this patient is not that long. Okay. That goes back to the ECG. What do you see here? Make sense? What you're telling us? Because of V6, now you have a S wave kind of pattern there, right? Yes, which wasn't there before. The previous ECG shows only pure R, right? Now you got QRS pattern. The EKG can change because the rate only change. The rate is not that super fast. It's maybe 150, 140 or so. So there's no aberrancy change anything different QRS complex. So most likely you are reading correct. I think it's HR flutter 2-to-1. That new deformity of a V6, which was supposed to be absolute refractory period of QRS, should be no change compared to sinus. New change mean that probably HR activity is summating to the QRS complex. So this is a big flutter wave you see recording looks like. And then probably flutter 2-to-1. First difference of diagnosis. Second one is the HR rate, faster HR rate that can make a QRS aberrancy, but less likely. Why is that? QRS duration doesn't change. Okay. If you have aberrancy, you should have a wider QRS complex. That would make sense. But no other lead shows a wider QRS complex. That's against it. Okay. And then one more distinctive information. The patient heart rate increased from 80 to 150. You doing what? Somewhat low level treadmill test. If this patient was actively ischemic, what would you have as the T wave? Higher. Does not change. So your assumption is the chronic MI probably correct. Okay? Because when the heart rate goes up, your circulation reservoir goes down, and then patients should have a significant segment of changes. But I don't see that. So this is probably chronic. Okay? Anything add, Kofi?
no.
Okay. Last ECG, you had a 3 ECG today. Okay.
So this is
Now what it is?
same patient.
Same patient. Now what? What do you see? You have 2 fellow on it, so I have to go back and forth. And I'm
Regular rhythm. going to broad. Broad and
It is like, if this is.
PVV seen
Here it's in where?
to lead one.
Lead one.
Mm-hmm.
So what are you saying? This is
12, like 12 Taki or 12 flutter. And 12 flutter with aberration.
aberrancy.
I think.
So what's the rate about this tachycardia?
Rate
Rate.
above 150.
Okay, compared to the previous ECG. Copy shows the previous ECG. No, flutter. Yeah, this is ECG. Okay. So look at the lead 2, okay? Go back to the tachycardia. Is it possible? Changes that much ECG axis?
Mm-hmm.
Simply
Yes.
because of a flutter conduction fast conduction, make it that kind of change, you think?
Yes.
So what's the QRS axis, this tachycardia? Lead 1, positive, tallest, the widest, right?
Mhm.
And then lead 2 has a small S wave, but the 3 AVF have a deeper S wave, especially lead 3 has a deeper S. AVR, negative.
Mm-hmm.
So that? And then AVL, positive. In sinus rhythm, this patient AVL was positive. Remember that? Right there. Now we get negative. And then QRS is wider, right? And then, as you point out, look at the lead 1. 1, 2, 3, 4. Number 4 beat before. There's some sharp mountain kind of thing. Lead 1, not B1. Lead 1.
Lead 1.
Yeah, for that guy. What is that? That sharp top guy. Why the other complex don't have what that thing has? Is it coincidence? Oh, and then also you can see a lead 2 now, second complex, lead 2. Just before that, S segment, tall P, like no, before, come to the left, a little bit more. That guy is different than other, right? So there is potentially some atrial activity that perhaps independent of this QRS rhythm. Yet your QRS activity goes on, right? Regular, you said, you read it well. So this patient has a left bundle branch block pattern. You're going to read ECG. Wide complex tachycardia, faster than flutter rate that we read before, is about 180, 190, maybe a little bit close to 200. Okay. And then what is the most remarkable thing about the before? Take a look at the before. No, before. What do you think about this QRS complex? Very much notched, very bizarre looking thing, right? So my mentor always said, when you look at the bizarre thing, why the complex, think about VT first.
VT?
VT.
Oh.
And then you look for, see there's any other evidence of a support of VT. I want you to look at the lead 2 now carefully. Lead 2, bottom tracing. Yeah. Look at the SDT wave segment there after the QRS. Keep going. You keep changing. If it's a flutter driving ventricle, that should be very consistent, right? Like the previous ECG. This one keep changing. There's no pattern to it, right? Like someone like a dirty looking S segment, what I call. This is what? Patient have a atrial activity, or patient may not have atrial activity, maybe in fibrillation now. And fibrillation doesn't give you regular rhythm, right? Irregular rhythm. So this can be fibrillation. Probably 2 different rhythm going on. So I think in probably atrium, most likely could be an atrial fibrillation. And bottom is a VT going on. Okay, that possible differential diagnosis. And the second one you said it could be aberrancy. I don't think is unlikely because of your axis not consistent with any left bundle or right bundle pattern. QRS complex. If you have a left bundle pattern, right bundle block pattern, what do you expect to see? Certain pattern. But you don't see that aberrancy pattern before, like a complex. Look at the before precordial, all this noise. You seldom see that. And also, all the teacher told us that when you see such very complex fragmented QRS complex in ventricular tachycardia, also means some prognostic implication as well. Patient is poorly prognostically outcome long term. So those has to do with the EKG abnormality. Okay, Kofi, you want to add anything else? What do you know about this patient?
This is an 84-year-old male.
Okay.
Known case of ischemic cardiomyopathy. Most recent ejection fraction, 7%. He's had an ICD already implanted. History of stable angina, atrial flutter, VT, other comorbidities. This is his chest X-ray with the ICD in situ. And his most recent echocardiogram showed an eccentric left ventricular hypertrophy, akinesia of the anterior septal and apical walls. Left atrium dilated, left atrial filling pressure elevated. Worsening diastolic dysfunction, currently is at grade 3 diastolic dysfunction, and with a moderate pulmonary hypertension. And as part of his workup, he had an EB scan, which showed a severe large perfusion defect in the anterior septal and apical walls. So he was still having ICD shocks despite the antiarrhythmic, and VT was induced 2 days ago.
Oh, I see.
Yeah, so yesterday he had an ablation done for the.
So where the ablation was done in Ghana?
No, here.
Here.
At the left mid-anterior septal wall and apical wall.
Apical VT.
Afterwards, no VT was induced. So we'll continue observing him.
Okay. I'm glad that he's doing okay this morning. He's alive still. The first question.
Yeah.
Big enough.
I think it evolved after the procedure.
Because anticoagulation.
Yesterday.
I say
200 milliliters. But that amount
was dark blood or bright blood? Dark venous bleeding. Yes.
Yeah.
From the coronary sinus.
He's in the CCU now.
Okay.
He's keep on having sinus tachycardia.
But I think because it's a heart failure issue.
Yeah.
So you need to probably have all the beta blockade, all the heart failure therapy should be started today. But he was hypertensive yesterday.
Yeah.
Still it's a little bit pressure is a little high side still.
After pericardial stenosis.
Went up. So then you do need to have some, So conduit yesterday actually interesting issue came up. So you have two issues there. In the aggressive approach would be if you really want to be safe as possible, I would put a pericardial catheter right there, the pericardial puncture. The reason being, you may need epicardial mapping anyway. That patient, your patient, behaving mixed cardiomyopathy pattern. It's not a pure ischemic because you do not have any defined area of scar in the cardiac standpoint. In coronary disease patients, ischemic VT patient, even though diagnosed ischemia, they sometimes present mixed syndrome. So you have to go epicardial about 10% of the time. Okay, it's well known. So because it's ischemic, all the scar may not be necessarily be on the subendocardial endocardial area. Second point is that he already the bleeding has an indication, it's a stability issue. You want to worry about monitoring bleeding. Just put a pericardial catheter puncture. That's the best time to puncture because you got space to nice separate out. You can see an X-ray where the contrast is. Poke it, put a catheter in, and then you do the procedure safely. Okay. And told you yesterday it's going to stable enough to do the procedure when I looked at risk of bleeding. But aggressive center death would be the best approach. And then if you needed to, you got pericardial access, just put the catheter in, map it, kind of ablation. Okay. And second point is that you had a little bit of a challenge in mapping yesterday, anterior wall high. Epicardial, that would be laryngeal. Catheter just goes right in. Okay. So that is pros and cons in there. So sometimes need to be aggressive. Dr. Park wisely concerned about the patient age, clinical condition, renal failure status is worried. But sometimes aggressive approach may be better off. Okay? Then you don't have to drain pericardial fluid last evening. You don't return out. So that's the whole point. So you can look at the always problem, 2 different angles, decide what you want to do. Okay?
I have a question on the
Yes, sir.
ECG. So with the VT, typically we say that if you have a low bundle morphology,
Mhm.
it means it's coming from the right side.
No, oh, okay.
That's the typical
Sure.
description.
Okay.
Looking here, we see a clear transition of V4 to V5,
Mhm.
which suggests to me that this has an apical towards lateral wall origin.
Right. Low toward the low origin.
Yes.
Yes.
Of the left ventricle.
Mhm.
So how do you marry that with this morphology in V1 suggesting a right-sided origin?
So this is a diagnostic challenge of septal BTs. Because involve a septum, look at the intricate activation time, how fast that is. Typical left bundle morphology BT origin of the RV would be very sluggish. Okay. This one almost like a bundle. So yesterday, I did tracing. What this guy involved? Classical first. Conduction system activation first. It's a tracing, intracardiac tracing for BTs. So you can see during the nether complex become wide, what happened? This back classical come out, you conduct faster. Okay, so it's classical is involved, anterior classical involved. That's why they're fast. Yeah, that's the reason. So not all the VT, even crux PVC example. If you're coming from the right at the MCV, you would have a right bundle morphology. You wonder why the right bundle morphology MCV would be more, because can involve posterior septum first. So when you septum involved, you will see typically that start drop. So when you show me ECG, I said, "Well, this is involved septum. We need to look into that." That's what I told them because of the reason. Okay. So initial quick activation of septum, especially V1, V2, V3, still present in the precordial septal area. You're going to see deepest stroke. Okay. Yeah. That, and then V4, you see that V4 area? That's a high degree of notching fragmentation. That is where the tachycardia circle most likely, which was a little more apical. So we ablate that area yesterday. And the mid-ice potentials that we recorded beside this fascicle, this guy was a mid-diastolic one and the more lateral than septum. That's he ablated yesterday. That was a little higher one. Okay, that's what it is.
This ECG is not the initial.
Yeah, in CBT, right? But
it was in the CT.
I think he had 3 different morphology VT I saw on his record even before the case, because when septum involved, you depend on clock or counterclock rotation plus the horizontal and vertical axis, your VT morphology can change quite a bit. Okay, yeah. But I was happy to see that fascicular potential involved. I said, well, this is going to be easier to ablate because it's going to be endocardium, subendocardium, right? So he didn't ablate too much yesterday. It was inducible. So we're lucky for us. We do not tolerate that kind of procedure. So Dr. Pag asked me, hey, I think we better quit ablating this patient. He kept asking me that question. I said, you're going to be stable. I think you're going to be done quick. So that's how we pursue. Otherwise, I'll just stop too. He's a wise man, but then sometimes he can be also a little bit wrong. But it is a judgment call. Okay? So look at the thinking. So anatomy is very important as well. If you recall such a fascicular potential involved the PT circuit, circuit is very subendocardial, so you can ablate quickly. But if you don't see this, then you have to really think about it twice to this. Okay? Yeah, we learned a lot yesterday. It's a very good case, so I think. And then always remember mapping John Miller technique. Don't try to go directly, okay? Or sweep it, yes.
Thank you very much.
Thank you so much. Okay, like about time, 9 o'clock, perfect time.
I came back yesterday
아리조나 괜찮았어?
from Arizona.
로드릭 살 많이 쪘어?
Uh,
그치? 오래 만났는데 좀 뚱뚱해졌더라고요. 야, 운동 안 하는 거 시간이 없다. 원래 스키니한 게 굉장히 스키니하네.
So today's case will be presented by Dr. Karelma from the Third State Central Hospital, Mongolia. And we are honored to have Dr. Quinu Lin from Mandalay General Hospital, Myanmar, serving as our panelist. So we look forward to an engaging and educational discussion. And if you are ready, please start, Dr. Karelma.
Okay, good morning, everyone.
Good
Hello
morning.
again. My name is Girma. I'm working in the Third State Central Hospital of Mongolia. And today I'm just going to talk about one case. It's really smooth case. So Saturday morning, we'll start just some general cases. Can I share my slide?
Yes, you can share.
Okay. So the patient was a 69 years old woman who had the recurrent palpitation. During the palpitation, she feels fatigue and dizziness. And since 2000, so she had a very long-standing frequent palpitation. The patient had the arterial hypertension, no other comorbidities. This is the baseline ECG, but the speed was the 50 millimeter seconds, and the echo was quite normal. And this is the ECG. The narrow course complex tachycardia, heart rate is around 169 per minutes. So we are going to decide this patient in IMPEDE study. This is the baseline ECG, baseline measurements. So AH interval is 51. The HP interval is 31, and quartz complex around 92 milliseconds. And so we are going to start the EP study. So there is any, starting from the RV pacing, there is any retrograde conduction. So there is nothing. The concentric atrial activations shown. And we also check that there's any VA decrementals. So there's, we see that there's a VA decremental. And after that, we are trying see there's any antegrade conduction. So right atrial, incremental atrial pacing started. And after the atrial extra stimuli, we are seeing easily inducted this tachycardia during the before the induction. There is a AH jump and SVT induction. And but during this tachycardia is not stable, so we are not sustained. So we are trying to induce again. So 380. We are trying to induce two. One is the atrial extra stimuli, 550 to 380, and they jump and this SVT induction. And after that, we are easily induct this SVT for right atrial incremental pacing. And we are going to see the differential diagnosis for the SVT cases. So this is the his refractive PVC during the tachycardia. There is nothing changed for the atrial following A, and also check the AV reset. There is also no AV reset. So unfortunately, I thought that this patient who during tachycardia we already checked the walk response, and there is a VAV response during the and also PPI minus TCL is 125 milliseconds, and no V resets and no AV resets, and this is the brief conclusion about its typical EVNRT. And we positioning our catheter like that. Sorry, this is not, I think. Our catheter is positioning like that, and the first view is the layer view, and the second view is RA view, and the way I'm positioning like anatomical ablation in this patient because I couldn't find the slope pathway potential, so I just following the anatomical positioning, and I tried to 3 attempts in this patient. First 2 is failed, so third one is successfully. Just starting the ablation, we are easily see the junctional rhythm and keep continuous around total 59 seconds of ablation. And after that, we try to induce again, and nothing inducible. And after that, we wait for 15 minutes, and then check again, aggressive EP study. But before the ablation, the AERP is around 280. Now is after the ablation is AERP is 330. And this is really cute, and there's a slope pathway modification is effective. The post-ablation we try to induce and check aggressive EP study, but nothing inducible. So this is the, I think, successful EVNRT ablation. Thank you for your attention. I'm really shook. Too short.
Okay, thank you. And congratulations to your case. And any discussion and question from the Dr. Queen Oluin?
Yes. Can you hear me?
Yeah.
Yeah. Sorry for some disruption from my side because of some electricity fault and in my hometown. That's why I cannot catch up your middle part of presentation. But finally, I got the electricity back. I saw a conclusion slide. Sorry for that. But as far as I'm case, your presentation is slow pathway SVT, right?
Yes.
Yes.
I just okay.
Yeah, it is as typical slow fast AVNRT, you mean?
Yeah.
Yeah. So sorry for that. Is there any problem in your EP during EP study? Because I cannot catch up your middle part of presentation.
Okay, now I will show this.
Sorry for that. Sorry.
Not necessary, because in this, I just want to show the other colleagues and other attendants, because I'm the younger EP doctor. So AVNRT is a not simple procedure for us. So I just want to clear
Yeah.
EVNRT ablation. So in this patient is 69 years old
69.
woman.
Yeah. Yeah.
Yes, who had the frequent palpitation since
Yeah.
2000. And this is the baseline ECG. She
Mm.
had only the atrial hypertension, not
Yeah.
no other comorbidity, and
Yeah.
also echo is quite normal.
Yeah.
This
This
is the
is the
baseline
narrow. Yeah.
narrow course tachycardia,
Yeah.
and this is our basic episode measurement, basic
Yeah.
baseline measurements,
But
and
sinus and
everything,
within normal. Yeah.
yeah, is quite normal.
Quite
And
normal.
after that, we check is there any retrograde conduction or
Yeah.
not? So there is nothing.
Nothing. Yes.
And after that, we are also going to check is the VA decremental.
Mm.
The patient had the VA decremental, so the patient had the. And after that, we check the antegrade conduction,
Yeah.
and
Is it decrementing? Yeah.
yes, the patient had the decremental properties.
Yes.
And we are easily inducted,
AHCM.
yeah,
Yeah.
induction for this patient.
Mm.
But the tachycardia is not stable.
Yeah.
It's very easily to stop. We are trying to differential diagnosis may never do the tachycardia, but it is easily stopped. And we tried few times, and after that, it's stable, sustained,
Yeah.
and
Yeah.
we try to do some maneuvers for
Yeah.
differential diagnosis.
Yeah.
And
Do you use the isoprenoline for
no,
arrhythmia induction?
no, we are not using any drugs for the
Oh.
induction, but
Oh.
only the problem was induction is not sustained.
Mm.
But after 2 to 3 times with induction for non-sustained ASVT, and
Yeah.
after that it easily it is stable, and we
Stable.
try to do some maneuvers for tachycardia
Okay.
for differential diagnosis, and this
Yeah.
is the piece refractor PVC,
Yes, right. Yes.
and we didn't see there is no change for following atrial signals.
Yeah.
So, and after that also we try to atrial and AV resets,
Yeah.
and also nothing changes.
Mm.
And unfortunately, I couldn't add the warp response. We ventricular overdrive pacing during the tachycardia we also check, and there is a VAV response.
VAV response.
Yeah, and PPI minus TCL is 125 milliseconds.
Yeah.
And there's no reset and no AV resets, and AH jump to SVT induction, and we are conclude that this is the typical AVNRT.
Yeah. So,
And okay.
okay. Yes, it's okay. Yeah.
And we are going to ablate this slope pathway, a typical AVNRT, and I tried to find the slope pathway potential, but I couldn't find it.
Mm.
And so I just doing the anatomical slope pathway ablation. But in this patient had the little obese, and difficulty of this ablation, the slope pathway anatomical vision is not, I think, not that low. It's around very close to the his, and I tried to ablate 3 times, and first 2 is failed because very close to the. I just always find the ablation point. There is a his potential, so I just more ventricular side, and ablate.
Have you used the long sheet? Oh.
Yes, in this time, mostly we are going to use the long sheet as a
Long
one.
sheet.
Yes, for EVNRT for safety. And this is the third stent. And we are doing the ablation. There's a junctional written
Junctional,
induction.
yeah.
Yes. And following
Stay junctional.
stay junctional and following total ablation time is 59 seconds.
Yeah.
And after the ablation, we are going to check IP study again.
Yeah.
There is nothing in the invisible.
Non-inducible. Yes.
Yes.
Yeah. Okay.
And we are going to wait for 15 minutes. And after that, after that, we give some atropine, not isoprene.
Not
Yeah.
isoprenylate. Okay.
Yes.
Yeah.
And after that, we check again. Everything is quite normal and nothing invisible. So we are finished these days.
So you say slow pathway modification. Is there any jam and echo after ablation?
No, nothing. So
okay.
I think
So
I already modified everything.
okay. So no jam, no echo beats,
No echo beats.
no echo beats. Okay.
Yes.
So you are successful slow pathway ablation.
Yeah.
That's
Yes,
right.
I hope
Yeah.
so.
Okay.
Yes.
Yeah. So so during ablation, when you get the junctional retention, you use the A basing during ablation?
No.
No. Okay. Yeah. So you are doing sinus during ablation.
Yes.
Okay.
Uh-huh.
First time you are doing ablation and failed
Mhm.
3 times by anatomical position, right?
Two times in another
time.
position, yes. And there is I saw that this might tiny potential is low battery potential, but this is not that close to the his point.
Yeah.
But this is failed. And third one is the last ablation point is this one.
Find this out. How much power and temperature used during ablation?
50 watts.
50.
Yes.
Okay. Temperature 65 or 55?
55.
55. Okay.
Yes.
Okay. Thank you. Thank you, doctor. You are very good presentation. And AVNRT ablation is sometimes very difficult for us, especially for finding slow pathway potential and very close to his potential. So using long sheet is a good for operator and for catheter stability. And now, is there any symptoms after ablation, patient?
No, nothing.
No, nothing. Okay. I think it's some question from the audience. Dr. Nilao's question is your next plan, if your anatomical 3-time ablation still fail, what is your next plan?
What's your next plan if you're
if you are still fail ablation in anatomical ablation?
Still try to ablate, but more safety, more lower part, and more ventricular side, far from his. And first, I try to not using the long sheet, just using the catheter, and then it's not stable and not effective. So we are going to try using the long sheet. And if you still fail it, I call the senior doctors.
Doctor, yes, that's
Yes.
right. Yeah, it's a very good answer. Yeah.
And we are trying to anatomical way. If it's really dangerous of during the ablation, maybe not good, you just stop, I think.
I think. So Please provide your suggestion. And Dr. Kim, your suggestion for this question?
Yeah. Actually, there was one more question from Dr. Kyo. Was ISO used to induce tachy after ablation or not?
In this time, we are not using ISO. In this time, we are just trying to induce atropine. But after the atropine, there is nothing inducible. So, and after the also EP study, there is no echo. So I think slow pathway is gone.
Did you consider CS venogram? It
No.
was not that successful. No.
Actually, yes, I heard about the CS venograph is very useful tool because we are going to use see clearly where is the CS os and anatomical slow pathway correctly because this patient little bit obese, so heart is a little bit horizontal, and we are just our SL1 sheet little bit maneuvered like this kind of shape, and we try to ablate this patient. But next time I heard about that is venography is very useful tool using just long sheet and gives some contrast and easily to see the CSOs and exact the anatomical or anatomic of the patients.
And I'm not sure your LA view, the ablation catheter and his catheter is located on the same plane. So that might be the key to success. Maintaining the ablation and his catheter the same plane, and we can adjust the LAO angle for his catheter to look us directly.
Yes.
And not oblique angle. So generally, it is recommended to adjust the angle, not fix the angle, LAO, such as 35 or 40 or 30, and adjust the angle according to the patient's rotation. Get the best angle for his catheter to look just directly us. And I would now like to open the floor for questions or discussion. Any discussion from Korea? Dr. Hwang or Dr. Jason or
Anyone else has any question before I make a comment?
I have one question.
Yes.
Because in this
I'll
patient,
comment. Just a second. I comment for you, and then you can ask your question. I may answer all your questions. Okay. Any else, buddy in the audience, please. If any comment, question, please do now, so we can discuss this case. Okay, looks like no one. All right, let's go over this thing. So you have a 69-year-old female, hypertensive.
Yes.
Your presentation missing few things that I think is very important. One, height and weight. Why is that? If your height is short, patient is overweight, your heart going to be more horizontal. That means tricuspid angle is going to be more tilted. So your space between his bundle and coronary sign is going to be narrow. That creates a challenging for you to map the patient. Okay? So for juniors who see the patient in clinic, let's say you have a SBT patient, very tall guy, slender, let's say 180 centimeter height, 50 kilo. I'm just exaggerating. Then you imagine that person going to be very long and skinny. What is his heart going to be? Pendulous, right?
Yes.
So that means tricuspid is going to be more vertical.
Yes.
So then his bundle to the CS is going to be far away.
Yes.
The other hand, patient like yours, heart going to line down at the top of diaphragm. Your tricuspid is going to be tilted. so that his CS get closer. That created a challenging issue. Okay, so there is a biophysical dependent risk of heart block during the AV node modification. Is it important you put that in data? Matter of fact, every EPK should be. Okay.
Okay.
Second thing is your catheter placement is not very clear to me. If you go look at take a look at your X-ray, please. You show us a briefly ablation site, the X-ray. Dr. Kim already commented a little bit. Just show the slide. Can you project your slide so I can make a comment on that?
Is it?
Let's see. Yeah, there we go. So Dr. Kim comment is a very valuable one. One is that the area view, okay? You need to make more area. That is, your CS has to be completely vertical, okay? Area, stiffer view. And then his bundle catheter will see evenly spaced electrode spacing. You see, your image is very fuzzy here, okay?
Yes.
Number two, your RV catheter is in the wrong place. Why? You put in the septum.
Yes.
In SPT cases, you really don't want to put a RV catheter in the septum because you end up favoring right bundle. Then you don't get too much differential diagnosis among AVRT, AVNRT, junctional tachycardia, nodoventricular tachycardia. That's all possibility you're discussing. Okay?
Okay.
So I suggest you read the paper by Dr. Scheiman, Melvin Scheiman. He discussed about the RV catheter placement importance, relationship to the differential diagnosis SVT. Please read the paper. This is a fundamental paper you need to read. Okay. Now the LAO view, you can see that Dr. Kim already mentioned his bundle needed pointing at you. That means stiffer LAO. Okay. Therefore, there's no fixed angle of fluoroscopy for each individual patient. You have to find the patient's heart different. And obviously, this X-ray shows what? Area view. Patient heart sitting over the diaphragm, very much horizontal, as we expect. So that's why the X-ray view looks like your ablation catheter is close to the CS rather than his. Then you're misleading. You think that the closer his. No, your CS catheter inside the CS. Okay?
Yes.
So that is important. I want you to go back to the ablation signal now when you ablated. Show me your ablation site EGM.
Okay.
Okay? Okay. So what is the ablation signal shows here? Pointing out to me.
There's a.
Can you point with the arrow so everybody see it? Your CS first, then his, and assuming that's ablation, right? Ablation shows what? Big A.
Big A.
And B. Big V.
Yes.
So you gotta be closer to the annulus, right?
Yes.
But then look at the timing of your activation of ablation, distal and proximal. They're same time with what? CS. Draw the line there. Okay? If this was in septum, you should see closer to his, not the his A, not the CSA. This is a proof that you're not in the septum. Make sense?
Yes.
Okay. Then what happened? There's no slope at the potential that we can see, but you burned it. What happened? Junctional rate, or you don't know. You may be triggering slower AVNRT.
Yes, I think
because your activation sequence is exactly the same as the tachycardia. You see?
Yes.
This is a time that what you need to do to make sure that you're not ablating some sort of a conduction tissue, since you're not sure you was a CS or not. For safety reason, if that happens, you need to stop ablating. And then you pace, make sure, confirm this is our AVNRT, or this is a truly accelerated junctional rhythm. Now, lucky you that this is a first part is the AVNRT. If this was an accelerated junctional rhythm this fast, you've been heart block.
Yes.
In other words, if you start delivering RF energy in the for slow pathway, your junctional rate exceeds more than 110, your risk of a heart block increase sky high because you're ablating close to compact node. If you're ablating further away from the his bundle, whatever right posterior extension, distal tip, your junctional rate increases gradually, not this sudden onset of tachycardia. So this is something that you need to make sure that you're ablating right spot. Okay? Matter of fact, if you look at your during the tachycardia, okay, look at the ablation signal, which A is earliest. Your ablation A is earliest.
Earliest, yes.
Yes, that's supportive of this is a tachycardia, not the junctional rhythm. Okay, then go on next slide. Next slide. What happened here? Gradually, you kill that guy, then tachycardia slowing down. Your heart rate varying. Okay, so irritating one and up. Then next slide. You had one more slide. There you go. The after pacing. Okay. So it is make sure that you wanted to stop pace and then pace H from this point faster than junction rate. Make sure there's an antegrated conduction of AV node. Then you can ablate more after that. Okay. For safety comment. Second thing is that I'm a little worried about it. Is that your anatomical approach of AVNRT slow pathway modification. Year 2026, I'm not sure that is the acceptable practice among Korean, electrophysiology people, because if you do anatomical approach which you developed early 1995, so on, by Milwaukee group, he's Dr. Matsuzek, he's a big time EP doctor in the Milwaukee. He developed this anatomical approach. That is not really something we want to do. You want to be more target specific slow pathway potential guided ablation. Okay? So if you have an interest of learning that, you can shoot me an email. I'll send you article, anatomic data, all the review article for you to learn. Perhaps change your mind. How do we approach this? Okay? Or anyone interested in the articles, please send me an email. Then I'll be happy to give that to you guys. Okay? All right. So please try to understand anatomy, and then press understand electrophysiologically, and then you find the slow pathway potential ablation. That reduces risk, also number of RF application you require to eliminate slow pathway. Okay? And then finally, Dr. Kim's suggestion is a very important one. If you don't understand anatomy, do CS venogram first to understand where the CS os is, where the main body is, relationship of septum. Then once you see it, you can manipulate catheter much easier and with a confidence. Okay? All right. Good case. Thank you for presentation.
Thank you for your time and kind suggest. And I always curious about the slow pathway potential, because it is, I think, not easily to see. So after that, I read more and try again. Thank you for your kind advice.
Dr. Kim, back to you.
Okay, if there is any questions or comments from the others. Cambodia, Malaysia, Dr. Manuel, no comments?
One more trick that I just forgot to tell you. Let me comment quick. If you really don't know where the slow pathway is, you did the VA Wenckebach pacing. Did you have a VA Wenckebach cycle? VA conduction Wenckebach? Did you find it?
Have it.
You have
find
it. Yes, find it. If you look carefully during the VA Wenckebach, the reentrant tachycardia patient will also have a retrograde VA jump. Okay? That particularly seen during the VA Wenckebach cycle. So during the anterior exit of nodal conduction, the VA conduction, and then suddenly shift to the posterior because of slow path activation, that earliest retrograde activation of the septum that area typically slope pathway is. Okay? So that way you
Okay.
can find the area relatively smaller, map that area, find the initially slope pathway looks like a potential. Then that'd be safer thing to do. Okay? That's the tip for you, since you don't know where the slope pathway is. Okay?
Thank you.
Okay, I would like to thank Dr. Kirama for this case presentation and Dr. Kino Lin for the insightful discussion. And thank you for all your participation. And let's conclude today's session. Thank you all.
Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you.
Thank you.
Right.